Welcome to the ParentInfant Foundation podcast. I'm Dr. Karen Bateson, the Foundation's Head of Clinical Strategy and Development. In this series, I'll be discussing various aspects of setting up, delivering and sustaining a specialised parent-infant relationship team. I'll be talking to parent-infant relationship practitioners, who's involved in commissioning and managing services, and getting relevant perspectives from other sectors. For more information on how to set up, deliver and sustain a parent-infant team, please download our comprehensive development and implementation toolkit from parentinfantfoundation.org.uk. Over the last year and a half, the National Lottery has funded the Foundation to work closely with ePut NHS Trust, the CCGs in Essex, Thurrock and Southend, and the National Lottery itself to support a new team, together with Baby, during their first year of delivery. This podcast series is supported by that National Lottery funding so that we can share our partnerships learning with areas that may be thinking about or already developing a specialised parent-infant relationship team. In this episode of the Parent-Infant Foundation podcast, we're going to talk about the work the Foundation has been doing to help a local area set up a new specialised parent-infant relationship team, the Together with Baby team in Essex. You'll hear about how the team was set up, some of the decisions and challenges which they faced along the way, including COVID, and what they've learnt during their first year. First, I talk with Helen Farmer, the commissioner who started it all back in 2018. Helen is the Assistant Director of Integrated Commissioning for Maternity, Children and Young People at Thurrock CCG. Helen, can you tell us a little bit about what that involves?
Yeah, so I'm responsible for commissioning services for children and young people in Thurrock CCG, which is a unitary organisation in Essex, and that involves commissioning services such as paediatrics, community services such as nursing, physiotherapy, occupational therapy, children's mental health services and hospital services.
So how did the idea of a parent-infant relationship team first come about?
Yeah, so it came about really because of the work we were doing around children and young people's mental health. Sort of as I'm sure you're aware that there's been quite a national focus on improving children's mental health, recognising the increased need that's out there and the need for our services to be more responsive and more accessible for children. There's also quite a focus on prevention and early intervention. And some national guidance for commissioners was launched around children's mental health, which clearly states that commissioners should consider services from the ages of 0 to 25. So I suppose that raised the question around how are we locally and actually with wider partners, because within Essex we work as a collaborative across 7 CCGs and the 3 local authorities, so there's 10 commissioning partners covering the whole of Essex, to look at how we were commissioning services for that age group, and particularly the sort of 0 to kind of 3-year-old age range. I was also given the responsibility for working on the development, working with colleagues in providers, units and trusts to develop the perinatal mental health service. Within that piece of work, we were invited to attend a series of workshops run by MABIN, Mothers and Babies in Mind. And one of those workshops was actually focused on infant mental health. So that was my introduction. I then went back and spoke to lots of professionals locally, and we had a very experienced and knowledgeable health visitor who really introduced me to the topic area and the work that they were doing locally. And then from that, really clearly identified a need for us to think about having an infant mental health service for the whole of Essex. So that's how the journey started. And once I started the conversation, there was all kinds of narratives that came from a wide group of stakeholders recognising the importance of that early intervention.
And you started by talking about what families need. You said about the need to improve services or improve access to services. So how did you go about understanding the needs of that community of babies 0 to 3 and their families?
Yeah. So first of all, sort of commissioners will tend to look at, well, I certainly did look at the evidence and look at what's out there, and the 1001 days sort of strategy had clearly been established and mentions the importance of that early connection and relationship with babies and care and nurturing that babies need to have antenatally, as well as after following birth, and how important the importance of the brain building blocks are at those stages, and that's a window of opportunity that's so important. So it started off with the evidence. It then started off with talking to professionals. It was quite, I suppose, if I'm honest, it was quite challenging to talk to families and mothers and carers, because I don't think it's a subject that's widely understood, and can cause a level of concern when you're talking about babies' mental health. How does a baby have mental health? Surely not. It's how do you see that? How do you recognise that? How do you focus on that? So that was quite a challenge, I'd say. But I think as we've opened up the conversation through the organisations such as the MVP, so the Maternity Voices Partnership, which is very much working with new parents and locally. So we had good conversations with them, and we also had good conversations through the specialist perinatal service.
I know it's really important to you to develop services that really meet the needs of local families, and it's really good to hear that you did a range of things to kind of get the views of families and engage them as stakeholders. Am I right in saying that local families had some hand in the naming of the new service as well?
Yes, definitely. So we did a survey when we started, and I think that was a very interesting journey for us, wasn't it? Because I know you were involved in that at that time as well, and we thought about all kinds of names to that we thought as professionals would say, and in fact, it was a case where the professionals, because we asked professional groups as well, and they voted for one approach, and parents and mothers clearly articulated the opposite. So that was great, actually. I thought, we all learnt from that, and how important co-production is, and that's how we came to the name Together with Baby.
How did you find the money for a new team?
Financing for the infant mental health team came through the long-term plan transformation fund for children and young people's mental health through the NHS. So CCGs receive additional funding year on year for mental health. We have done for the last 4 years, and every area has had to produce a transformation plan for children and young people around mental health. I think there has been a big focus on the traditional CAM services. As I said before, if you look at the guidance around commissioning, it clearly states it's a naught, starting at naught. Now, for me, with the understanding I have and have built up with the help of all of you, there is no other model for naught to 2-year-olds or 3-year-olds. This is infant mental health is the mental health model that areas need to consider, so the funding is managed by a collaborative commissioning structure within Essex. So we had to develop a business case, which was then presented to fellow colleagues, because obviously there's lots of pressures on that pot of money. We'd always want more money as commissioners to spend on services, so we have to think carefully about what our priorities are and how we invest and use that money. But we got clear support, having presented the business case, to go forwards with it, and we were able to offer. So, although I'm leading on it from Thurrock, but it's on behalf of the other partners across the whole of Essex, and that's been really exciting to do it on such a large scale. and the money is recurrent money. So I think often the way funding streams work, it becomes quite challenging to ensure sustainability of services. And it's quite right that all services are reviewed and looked at in terms of impact and value, and making sure we're using public money in the right way and with the best effect we can. But I do feel that services need some stability and need some longevity to their funding, because otherwise you're just worrying all the time. For a service to worry about whether they're going to be there next year or not is an incredibly difficult operational environment to be in, I think.
Helen is a great example of everything we know about successful commissioning. From the start, she wanted to work in partnership, she wanted to follow the evidence, but stayed curious. She listened to the voices of local families, and most importantly, she wanted to make access to mental health services fair for all children. After speaking with Helen, I talked with the clinical lead of the Together with Baby team, Dr. Ellen Auty, a consultant clinical psychologist. Ellen and Helen first met at a marketplace event for commissioners and services, where Helen's involvement in the project signalled the green light for funding. It was Ellen who was in charge of developing the service and the team. Ellen, your new team is approaching its first birthday in September, so it's come through its conception and delivery and first year of life successfully. So how much time did it take, and what went into creating the case for change, the case for investment, securing the commissioning arrangements and the planning phase, really?
I guess where we came into the story of this is following the marketplace event, where it was like, actually we could put something together, we feel that we could meet this need, and from that point it was quite a quick turnaround. We had a lot of long hours, really. Myself and a business manager whose role within the trust is to procure new services and new business. So this for me felt like a real sea change, actually. I've a background of being a clinician for many years. I found myself immersed in language and kind of ideas around corporate commissioning arrangements and sort of very much corporate language. So I had to learn very quickly around budgeting, business cases, reporting, data performance, all sorts of things that are very necessary to show that you can deliver a service. So we had about 9 days to get together the detail, which is not long. It's a tight deadline. And then from that, we were then invited back with Helen and her colleagues to, for a better word, pitch our service. So I had to do a presentation and be there to answer questions, and then from that we then had about a period of, I think it was about 6 weeks, and then we heard delightfully on Christmas Eve that we had been awarded the service, which was a really nice way to start the year. So that was December 2018. So come January, started the new year, and then we were into the planning phase. A lot of the planning work was around the mobilising or getting the service off the ground. So we had to think all sorts of angles. Again, this was a real learning curve for me, because this is something I hadn't done previously to this extent. So we had to look at recruitment, had to get a team in place, we had to find the buildings in which to offer the service from. We needed to put together reporting templates, how are we going to actually receive our referrals and meet these families, to commissioning discussions around contracts. There was a whole myriad of things that we needed to do, but thankfully I didn't do it on my own. I had a very good project manager assigned to me by the trust, whose role is to create lots of spreadsheets and to make sure that we were keeping to a programme. And there were some real learning curves in that.
How important was the project manager role?
I'd say really important, because for me, again, being a clinician by trade and background, I didn't have the requisite sort of skills, immediate skills, to really project manage the mobilisation of this service. It was really helpful to have somebody putting together the step-by-step what we need to achieve by this date and by this point. But also what was really helpful with that is then we were able to communicate that to Helen and her colleagues and CCGs about our progress, where we got to, what we needed, what was possible stumbling blocks or obstacles. So that was very helpful to have somebody just to keep that thinking going and to make sure we were all on track.
What does clinical leadership look like as opposed to the project management side?
Whilst the service was being mobilised, I had yet to fully come into the role of clinical lead. So I was juggling 2 jobs at that time. And I found that tricky to sort of formulate in my mind about, how am I going to lead this service? Coming into that space and coming into that role meant I had to really think about, where is this service going to go? Where do we want it to be once we've got everybody in role? And essentially for me, it was about really embedding the idea of infant mental health and wellbeing in Essex, and for us to have presence in the county, and for families to have a point to turn to and to seek help from. So for me, it felt, in order to lead that, I needed to start from the get-go, informing relationships across the county, and really making sure that I knew where people were. And it was helpful to have some admin support to come in. So Jo came to the team first, because she was able to help me really map out. She created a fantastic map for me, which I have on my office wall, of Essex, and to think about the different areas we need to be covering and making contact with.
I think your map of Essex has become quite famous now, hasn't it?
It has, yeah. It's what I reference a lot, because it's such a large area, and you need to really be holding in mind all the time is the families who are at the very edges of the county, if you like.
And what was it like developing the relationships with the team, with your new staff, within the team, and trying to integrate all those different skills and knowledge?
So I suppose one of the things I was quite keen to do in bringing a team together is I wanted different skills. I wanted it to be a mix of people, because that's the background I've always worked in, and I've really valued, is having those different perspectives and different lens in which to see the case or the family or the patient. So bringing together people from, I think I've talked about before, we have health visiting, we have CAMHS nursing, we've got child and adolescent psychotherapists, art therapy, as well as clinical psychology. So it felt really rich to be recruiting these people, very exciting to recruit these people. But as you just alluded to, there is also the dilemma, I suppose, of how do we integrate as a team. And I think what helped was that people arrived sort of quite slowly, I suppose, just because of the nature of recruitment. So it was sort of bringing one person in at a time, which felt I got the opportunity to get to know them, they got an opportunity to get to know me, and then as the next person arrived, we sort of almost, just kind of growing, thinking about the parent-infant relationship, moving from a dyad to a triad and growing as a family. That's how it felt in the beginning. And it was exciting each time a new person arrived, because if you like, the family or the team got excited. It's like, oh, they're great, they're going to be bringing this, they're going to be bringing that. I think where we are now as a team and thinking into being after a year is, it's now we've got to know each other. It's more about how do we work alongside each other, how do we ensure that our voices are heard and our work is understood and respected, and all of those things. So we feel like we're transitioning again now into a different phase, I suppose. So that initial excitement of new beginnings, and now it's moving into, okay, how are we going to live together? How are we going to make this work?
It's such a lovely analogy of growing a family.
Yes.
I know that you gave a lot of thought to the training that you would do as a team rather than as individuals. Can you tell us a bit about that?
So I wanted us to bring the different skills and experience that we had, but that we were developing a shared language in which to understand families. So as part of the costings of the service, we ensured that there was a significant training budget to really enable the team to get skilled in order to be able to pass on skills to the workforce in Essex, which is part of the remit of the service. So that felt a really, it's almost felt luxurious opportunity, really, is to train together. So we, over this last year, have attended a number of trainings. It's enabled us to socialise as well as learn together. What we found is that through attending these trainings together, we've really then developed our referral process. We've developed how we think about meeting the needs of families who straddle a number of services, those that are needing or hold a lot of risk. So we're having those joint conversations together, and I think that's been very beneficial.
And so what was it like accepting your first referrals after all this work and preparation?
We decided to go for a soft launch, as it's known, rather than something that really shouted about the service, because what we didn't want to do was to get inundated and not be able to meet families' needs. And also I didn't have the staff, really everybody in post until the September. So in terms of the timeline from the inception of the service in the January to the September, you know, it took us quite a while to get staff in. However, I think just reflecting on that, I think we probably could have gone for a bigger launch, a bit harder maybe, because the danger is that people don't really know you or aren't aware of you. So I think in hindsight, perhaps we would have gone for a bit of a louder shout, as it were.
I guess it's really hard to judge, isn't it? Because you've got no idea, and you serve such a big population across a large geographical area, so the risk could have been quite substantial that you just get too many referrals, and with 2 clinicians in post you sink.
So when we started in that September, really fully as a team and being operational, the plan was then to build events in and to really start to shout about ourselves and get people's awareness created. And unfortunately then COVID's come along and we've lost that momentum, although we're building that again now. But that has been unfortunate.
Because you've had a year of 2 halves. You've had your first 6 months, you know, a launch and a gradual building and an extension of the service. And then come March, of course, everything's changed.
Right.
In what way has COVID impacted the service? What changes have had to happen?
Well, I think the biggest change is having to deliver an entire service remotely. It's something that none of us could have predicted. I think the biggest change has been the use of video and being able to communicate not only as a service and continuing all our service functions remotely, but also having to meet our families remotely or virtually. That's been a huge change.
No, I don't think anybody could possibly have envisaged this. But you've survived your first year despite all the challenges of COVID. And I know you've got Emma in your team who's been really innovative in terms of making sure you've got the software to support your video interaction guidance work. Can you just say a bit about how that's been to use video interventions by video?
So Emma's been instrumental in supporting the team in putting together the video interaction guidance online. I think what's helped is because she had the solid experience beforehand of delivering VIG, so she felt very experienced in delivering it, that actually coming to do it online became more of technical aspects. I think what she's brought to us as a team is that confidence, okay, we can do this, and she's got some very good results in using it. I don't think video isn't for every aspect of parent-infant work. I'd say that where it lends itself is probably use of video, although it requires the families to be confident to be filmed as well, and that takes some more probably engagement conversations than ordinarily would happen. And what we're doing as a service, we're putting together a guidance for our families on what to expect, how to connect, all of those sort of questions really, to set it up so that both people in the interaction feel confident and comfortable.
I was wondering whether, in hindsight, looking back over the last 12 months, whether you have been able to work with the families you had hoped to work for. Are the right families being referred in?
Yes, I think we want to be able to see more though. I think where we've found ourselves working predominantly are families with a lot of complex needs, and there has been discussions around us as a team thinking about what about the families whose relationship is under stress with their infant, their baby, but are not on the radar of social services or mental health teams or drug and alcohol teams. They're families who are struggling, but in a different way. And I think that for me feels the next area really of developing our service.
So looking back now over the last 12 months, what do you think the most significant decisions or learnings have been for you as a team?
I think from learning, there's, for me, I think it's been about understanding how important the reporting and the data collection and all of those aspects are. I mean, as a psychologist, I like data and I like to look at evidence, but I think what I've come to know and understand much better is you need the mechanisms in which to gather that at a much more broader level. So thinking about the systems and having conversations to get the right data.
So one of those key relationships was with your information department.
Yes, and performance and data, yes.
It's not uncommon for clinicians to find themselves on a steep learning curve about contracts, commissioning, and performance data when they start out developing a service. One of the reasons we at the Foundation wanted to work with Helen, Ellen and their colleagues was to see whether our support could smooth the way a little. And for the Commissioner Helen, that support for the team was a priority for her too. Helen met with Dr. Becky Lang, Chief Exec of the Foundation, and discussed how the Foundation could support the development of a team as an independent advisor during the procurement and development process. Together, we made a partnership bid to the National Lottery, which was granted in 2019. And you reached out to us at ParentInfant Foundation quite early on in that journey. I wonder if you could say a little bit about what the appeal was in that partnership.
As a commissioning organisation, we really do value the input of third sector and community assets type of approach to our commissioning. So that's the way Thurrock tend to work, which I think is a really positive one. Having set up new services before, you as a commissioner, you're often, you haven't got the finances to do the gold standard wraparound, support that services need when they go live. They're based on the staffing levels and the actual cost of the service. But often when a service is going live, especially one that's is unknown, people don't know about infant mental health services. They don't understand what they could offer. Why are they there? There's a lot of education, awareness work around it, and I think the partnership approach that we had that gave us that resource and expertise and knowledge to form a kind of a blanket around the service as they develop and they go live, and you've got new professionals coming together developing a new service, for them to feel that they weren't alone in a very big landscape such as Essex, which is huge, with multiple stakeholders, commissioners, etc. How it would have been, well, it was extremely daunting, I think. So to have a group wrapping around them, supporting them as they go through this journey in the first year or so of going live, I think has been a really, really good model for me to learn about, to share with other commissioners, and to say, look, when we start new services, we really need to think about how we do that how we support services and how we mould and shape and work together in sort of going forwards, because otherwise it's very hard for a team to get going, I think.
The Parent Infant Foundation was able to put that wraparound support in place thanks to the regional national lottery funding. And using that money, we employed Sarah Woodcock, an implementation support manager. I talked with Sarah to understand more about her role and what she has seen and learned over the last year of working with the team. Sarah, you came to us with a wealth of experience in project management, especially in the voluntary sector. Can you tell us about what you do in this role as implementation support manager?
Yes, thank you. Yes, I've worked for several years now as a project manager in various roles, and more recently in the charity sector. And this role is quite unique in how it's set up. It sort of steps away from a more traditional project management role, in that I'm working alongside the service, the Together with Baby team, as they get set up, rather than me having that direct implementation of the service. But what that has brought is that I'm able to provide support to the team as they go through the process, and that support is varied. So for example, there's practical support there in terms of helping them embed their service within the local systems, establish networks and across the county. But it also has an observational element to it, which has been fantastic. It's really enabled me to sort of step in with the team, spend time with them, really understand them as they go through the process of setting up a service, and has, I think, enabled them to sort of share their ideas with me, and use me as a bit of a sounding board, really, just to get an idea of what they think they could do, how that might work practically. The other element of the role is the evaluation that's being carried out by City University. So the evaluation team there have been looking at what works well with the service as it's implemented from the start, and through that process of the first year. And my role there has been largely around helping that process run a bit more smoothly, so facilitating conversations, keeping things on track. So that's where it does fit more with a traditional project management role. It's keeping the elements of the work that needed doing on track, smoothing the way for everybody, and just trying to make things a little bit easier for everybody, because it is, it's very difficult. There's a lot going on, so they're the main parts of the role, really. So it's really different, but really has been an enjoyable experience. So for me to be able to be welcoming to the team as they have done, it's, I have to say thank you to them for that.
We've valued your role with the team massively as well, because you've been our eyes and ears to absorb all of their learning, and that allows us to share it then with the other parent-infant relationship teams around the network. What would you say have been the important success behaviours?
What I think is a really, really strong success behaviour would be around good leadership, and the Essex team have that with Dr. Auty. It's having that willingness within that strong leadership to make decisions. So it takes a bit of courage to do that, but also it's been able to adapt to challenges as they arise, and inevitably they will do that with a new service. There's going to be hiccups along the way, different things they need to change and adapt to. But yes, it's also around keeping the dialogue open with commissioners, with service users, and also with the local workforce, so that you can keep those conversations going, keep that feedback coming in, and help develop and strengthen the relationships with those around you.
If other places in the UK are starting to think about starting up a parent-infant relationship team, what learning might you share with them from your experience with the Together with Baby service?
So I would say that first off, to establish a really good network of support around you, and we've mentioned that as having Helen there as the lead commissioner for Essex, that's really enabled that relationship between Helen and Ellen to develop and strengthen the service. But also with that guidance and supporting new teams as they develop and grow. The foundation have a fantastic toolkit that's really, really useful. It shows you the steps that you go through setting up a new service. So that's a really, really handy guide. And also there's a fantastic network of other parent-infant teams across the UK. They can share knowledge, what works well, what hasn't worked so well, and they're all at different stages as well. There are some more established teams, and there are some newer. So it's really useful to be able to tap into that knowledge and that network. But also, I'd say it takes time to embed a new service. But the Essex team have, I think, done that really well. They've grown the service at a nice steady pace. That's ensured that they're not overwhelmed with referrals, which could, has a knock-on effect with reputation there. They've been able to really grow and develop their service. And it's allowed them to really think about what they want that service to look like going forward.
One of the benefits of a parent-infant relationship team to any area is its ability to support the local workforce to understand infant mental health better and feel more confident to support the parent-infant relationship in whatever role someone is working in. Teams do this through workforce training, consultation, supervision, and facilitating reflective practice groups, all of which became a bit harder during lockdown. However, undeterred, the Together with Baby service have risen to the challenge.
I saw yesterday the new training plan that Ellen and the team have put together, and it's fabulous. 6 sessions of infant mental health content, reflective sessions in between. I think there's over 100 people signed up for it locally.
Wow, that's
so it's really I think the team are really delivering against that aspiration to really build capacity, and there's clearly an appetite amongst the workforce, the children's workforce, to know more about the mental health of very young children.
There are a number of services that we need to work with, but we thought we'd start in phased stages. We focused on those early years and health visiting first, and building on those skills and that knowledge with a workforce that has a presence everywhere with every child and every family. I'm hoping we'll have a real impact, and that's fantastic to hear. I know we had done a webinar, didn't we, as well?
Yeah. And a last question, Helen, do you have any reflections or learning when you look back over this journey?
For me, the learning personally has been around that partnership working and reaching out, being open. I think being really open and listening and curious about all of the information we're hearing. It's about working really closely with clinicians and experts in the field, which has always been, for me, I suppose, a very natural way of working. And I really look forward to the team growing and growing, actually.
I wanted to finish by asking Ellen, the team's lead, what tips she might give any other areas looking to develop a parent-infant team.
I think one of the things that I've valued so much throughout this process is other people coming into the mix. So, for example, yourself, Karen, and the colleagues at ParentInfant Foundation have been invaluable in being able to talk through ideas, to think about directions, think about the kind of service that we want to be. I think also, depending on the setup of other services, but certainly in an NHS provision, use your colleagues in corporate services. So don't feel you have to know everything about setting up a service. I couldn't have done it without the team I have here at the Trust, because I was able to pick up the telephone and say, how do I report on this, or how do I get this template together? So for me, it's not being afraid to ask. You need to ask. If you want the best service, you've got to get the people around you who are going to make that happen. And so that for me is, it's probably my top tip. Ask for help.
I know you've got some very exciting and innovative training plans to start in the autumn. So good luck with that. It's been an absolute privilege to walk alongside you through this last year. So really, really well done for setting up a really good service. And I guess we all at Parent Infant Foundation just want to wish you all the best for the next 12 months and beyond. I'm really grateful to all our guests for sharing their learning about establishing a new parent-infant relationship team. It's clear they're off to a flying start in Essex. The key message for me is that setting up a new service takes good teamwork. You need a commissioner who is supportive and understands the clinical area well, a clinical lead who can bring together a range of professionals and understand the needs of families and the local workforce. But also, you need those important people in business management, information departments, and in wider partnership organisations, because they're the people who help the service become embedded and function well. We hope you found this Parent Infant Foundation podcast helpful and interesting. Thank you for joining me, Karen Bateson. Our huge thanks to Helen Farmer, Dr. Ellen Auty, and Sarah Woodcock for sharing their thoughts and experiences, and thanks to the National Lottery for funding our work together. For other Parent Infant Foundation podcasts, go to our website parentinfantfoundation.org.uk. You'll also find more information on how to set up, deliver and sustain a parent-infant relationship team, and you can download our comprehensive development and implementation toolkit.